Okay, the recording started. So what we know about keratoconus? Keratoconus, it's a very disrupting and annoying disease that affect actually a very productive segment of our society, which their age actually around, let we say, in the teenager age that get from 15 up to 25 years, the prevalence of keratoconus more in this segment of our society, which it lead to a severe vision, vision problem, which cannot be mainly corrected by glasses. It mainly affects the adults and young adults, which may lead to a severe visual disability that it's well known and well recorded in literature. It is currently the most common indication for keratoplasty surgeries in many parts of the world, also that being documented. And the prevalence of the disease in our region in the Middle East, it's there and it's high, and we see it in our clinics. Although there is a paucity of the data from our region. This is mainly the research from around all the world, which documented, the incidence and the epidemiological studies about keratoconus. I tried to gather most of them, as you see, some of them they've been recording the prevalence in the population, the general population, some from the hospital clinics, and some through the college students even. And from our region, there are main two studies recording the prevalence, one from Saudi Arabia in Asir province that recorded by Dr. Abdullah Asir a long time, I think in 2006. Sorry?
يعني انا بتطلع يمكن انا ما بيطلعوا
بليز بدنا الكل
ما عم بلحق عم بحط من جايبته على السياره بنزين يا امري رح طلب
بليز بدنا الكل يعمل ميوت
والله عم يطلع لا يروح ما هو عم بيطلع عم بحطه ما قدامي اخذ.
Okay, I'll try to mute from my side. Okay, we'll continue. So that we have two studies been recording the prevalence actually from our region. One from Saudi Arabia, as we said, by Dr. Abdullah Asiri, that long time. And there's an update actually for this study recently. The prevalence worldwide was recorded as 2 in 2000. يعني شخصين من كل 1000 شخص أو من كل 2000 شخص حتى يعني keratoconus. So they consider it as a very rare disease that time. I'm following also the chat, sorry. So they recorded that as a very, rare disease because yeah, two cases per 1,000 is not that huge number, but recently they have found, no, the numbers actually is more than this. And there's another study from Al-Quds al-Muhtalla, from Palestine, from Jerusalem, that also reported the incidence in college students population. There is also a recent study from Saudi Arabia, from Najran بالسعودية, منطقة سهلية جبلية. They found that there are many cases also of keratoconus, and I don't know what's the link between, the mountainous area, because in Oman also we have done some research and some studies regarding, where, because that Oman, we have a coastal area and we have the mountainous area. So most of the keratoconus patients that we have seen, mostly they come from the mountainous area. I don't know what about Lebanon and the other countries, if they feel this the same, but what's the link? Is the high altitude, or because of this area they are having like something in common, like intermarriage, or whatever the other factors that still is not known exactly, but there is a genetic factor and there's environmental factor actually regarding the prevalence of keratoconus that is being recorded. And mainly also the allergic conjunctivitis, the spring catarrh, and the harsh rubbing of the eyes might lead, to keratoconus, as we say, as we know. So this study from Saudi Arabia in 2019 published. They are recommending more keratoconus screening and recording of the epidemiological data in Saudi Arabia. In Oman, we did this study in 2000, I believe, 4, regarding, that this is from Armed Forces Hospital, where we have a keratoconus dedicated clinic, an optometry clinic for non-surgical management of keratoconus, where we see most of the referral which comes to the tertiary hospital that we've been working in. And from that, we recorded, the incidence of keratoconus cases, the severity, and also the gender-wise, male to female ratio, and the severity of the disease, and what is the treatment previously have been, done. As you see, this is some of the results that gender-wise almost equal. And the participation of the patient was around 458. And the total number of eyes being screened around very close to 900 eyes. The main 2 reasons that link to the disease is the family history was positive, and the allergic conjunctivitis as well. And the main age of incidence was between, if you can see from the chart, it's between like 16 years of old until 25. So we recorded also the visual acuity and corrected visual acuity in this segment, which was mainly, if you can notice that the majority of them, they are having visual acuity which is less than 660. And when we apply, the non-surgical management, like that we say the contact lenses, the visual acuity mainly improved dramatically up to even 6.6. That main segments, they're showing like 72% of those patients being managed with specialty contact lenses, all different modality of contact lenses that give them a very good visual acuity. And also we recorded those patients from where came from Oman. We want also to draw a map for Ministry of Health, for the allocation of the resources as well, because the secondary hospitals on the regions where they don't have, an establishment or a facility that actually is dedicated to a keratoconus. So we want to put some data in front of the Ministry of Health planning team, that they will know the major cases that we have received in the tertiary hospital in Muscat, they came and referred from where. So this is showing that the different cases came from different parts of Oman, but mainly from a certain area. As we mentioned, that is the majority of inside part of Oman, the mountainous area actually. So male to female ratio of keratoconus is 1:1. Almost 90% diagnosed by the optometrist. And I'm giving actually this presentation here today to see what is our role actually, or the main role of optometrists in the keratoconus management. And one of these roles actually, that the early diagnosis of this disease. And when we talk about the early diagnosis nowadays, is not like 20 years back. Early diagnosis of keratoconus 20 years back was not as important as today. Why? Because there was no actually treatment to halt, the progression of keratoconus. But nowadays, and for the last, I believe, 10 or 15 years, when the invention of the cross-linking procedure being there in clinical use, and applied by the ophthalmologist to halt the progression of keratoconus cases. The early detection of the disease is one of the very valuable, a game changer for the life of the keratoconus patient. And if we know that the majority of these cases diagnosed by the optometrist, so this is actually one of the main rules that we have to actually take it because this is our responsibility actually. So the main age of diagnosis in that study was like 22 years. 22 years for the keratoconus, diagnosing. It's a little bit late. We would like to pick up the cases even below the age of 20. As we saw, as we said, it's early detection. That means the progression or the later on management will be much easier for those patients. Keratoplasty actually, or the nowadays it's been done mainly in clear corneas, not like before. Clear corneas, we mean that the cornea which doesn't have, like corneal opacity or any kind of disease cornea that make it untransparent, like the trachomatis sequelae before a long time in our region. But nowadays it's being done mainly in keratoconus patient in the severe cases, or sometimes even in moderate cases nowadays, because there is a different modality of these surgeries recently. But also we know that the visual outcome of the RGB lenses or the specialty contact lenses that we use to manage these cases is much better if we, than the visual acuity or the visual outcome that comes from the penetrating keratoplasty surgery or other surgery, other modality of corneal grafts. In Oman, and I believe also in our region, I separated the keratoconus patient as two groups. One we call the lucky group, the lucky one, keratoconus patient, and the unlucky one. We'll talk about the lucky one in the scenario of Oman, let me say. A lucky keratoconus patient is a boy or girl, is under the age of 20, where we know that keratoconus can start, and with very early keratoconus, and the best corrected visual acuity with glasses reach 20/20 or 6/6. And this school boy or girl, okay, is picked by an optical shop optometrist. Notice that the scissoring reflex, because mainly in our optical shops, we don't use a corneal tomography, for screening. So we perform mainly, a simple tool and very, gold standard tool for the optometrist that called a retinoscope. A retinoscope reflex, when it's showing a scissoring reflex from the cornea, that actually might indicate some irregularity of this cornea. It might be keratoconus, it might be something else, but if we notice that, so we should refer this case, to a further investigation. Let me say, to do the pentacam or other corneal tomography mapping to confirm that this is a keratoconus patient or not, and to stage, the stage of that keratoconus patient for further management or follow-up. So the lucky one, which we've been picked, by that retinoscopy from the government hospital or from the private sector or from the optical shop. And then that ophthalmologist actually, which the optometrist referred to in the government hospital, that we say, that they be convinced actually on the result of that only retinoscopy screening of the optometrists saying that there's a scissor reflex. Because what happened, an early stage of keratoconus, in very early, even clinical keratoconus, usually slit lamp signs will not show up. So the ophthalmologist will find very difficulty to see, that the prominent, signs of keratoconus in the slit lamp. Instead, actually, the optometrist can pick the early cases by only performing, the retinoscopy. So if the ophthalmologist trusts, the screening result of that optometrist and refer, this patient for further management in one of the tertiary hospital here in Muscat. We call it another hospital, the main tertiary hospital, which manages such cases of keratoconus, and they get very early appointment within 3 months, which is nowadays not possible. This is we call it a lucky patient actually. So what will happen to that patient? They will do the corneal tomography. They will convince, it's a keratoconus, and then they can do the cross-linking within 3 months from, the initial diagnosis. And after, the cross-linking done, then the ophthalmologist should refer back to the optometrist, where the optometrist will prescribe only a pair of glasses or a contact lenses for this lucky keratoconus patient, and then he can, leave his life easily. But unfortunately, the unlucky scenario of the other keratoconus patient, when they get, delay in initial diagnosis by the optometrist. Let me say you are an optometrist actually working in optical shop, okay, or working in, let me say, even a government hospital. And an early case of keratoconus patient came for refraction. Usually, the old they said, you just concentrate on the keratometry reading. I want to draw your attention that keratometry reading and the autorefractor is not an indication really for early stage of keratoconus. Why? Because the segment, the autorefractor and the keratometer taking from the cornea is only the central 3 mm or 5 mm maximum, in that area. So usually keratoconus won't start from the center. Keratoconus mostly start off center. So in these cases, it will be very, very difficult to show abnormal keratometry reading until it reaches, the further stage of the disease. So there will be a delay from the optometrist side, and then there will be a delay for the referral to the ophthalmologist, and then again will be delay on the cross-linking procedure. The time is better for those patients because we know the disease is progress, very fast, especially in the age below 20. So nowadays we said that if any patient discovered below the 20, better to cross-link, not to wait even to monitor, because there is a high incidence of progression will happen under the age of 20. But if we have a patient which been diagnosed after the age of 25, we can wait actually to monitor, like every 6 months, we repeat, the corneal tomography, and then we say there is a progression or not. But as we discover early, below the age of 20, the cross-linking should be a priority. So the progression will happen to this patient, the visual acuity will drop, and then there will be a more hard work for the optometrist and for the ophthalmologist actually to manage such cases because of the costly procedure and the unavailable actually treatment. So the evaluation and the diagnosis of keratoconus, we know that we take the family history because studies saying that there's a link, genetic links and hereditary problems sometimes with keratoconus patient. So if you see a keratoconus patient, ask about their relative, are they normal? And believe me, most of the time when a family come to our clinic and then we do a screening for one of them, the others who are sitting actually and waiting, maybe they are more severe cases than the case that we are seeing. But because the people, they don't, those kids, they don't complain, we would not know. But also our responsibility actually to screen the other, family member if we have discovered one of the family having keratoconus. Corneal tomography, definitely the Pentacam gives us, now very more details and very comprehensive details about point-to-point keratoconus steepening, the thickness, the anterior, the posterior segment of the cornea. Keratometry, pachymetry still is a valuable tools, but the most valuable tool actually the retinoscopy. Retinoscopy procedure, which use the retinoscope to screen all and every patient that come to the clinic is very initial, and especially for early detection of keratoconus. And there is a study being published recently in one of the prestigious journal, is the Cornea Journal, one worldwide known journal, medical journal. And this actually study have been done in Oman that validating the retinoscopy or a procedure or the retinoscope for screening as a screening tool to pick up the very early cases of the keratoconus, and the conclusion being stated at this retinoscopy appears to be a very sensitive and reliable test for detecting keratoconus, including early disease. And such a test may be implemented for population-based screening for keratoconus cases. So it's a very handy tool, you know, the retinoscope, and very easy to be used. And the scissor reflex is, believe me, it's very unique reflex that anyone can detect it. So please use the retinoscope in your clinic. And if you don't have one, please buy one. So how often do you see, you know, keratoconus in your practice? Let's we say that you are working in an optical shop or working somewhere else in higher, you know, setup setting. So for keratoconus patient that you are facing, actually they are having a poor visual acuity that we know, and the poor visual acuity will lead to a difficulty in their daily life activities. Daily life activities for somebody who is 16 years, especially going to school, performing very well in school, and then later on searching for a driving license or going for a work or even going to the college. So all this will lead actually to social challenges, because if you have somebody who is suffering badly from their vision and cannot perform their daily life activities, they will be having a hard time to go to the college. And if they don't obtain a college degree now in our, you know, region, which can consider very, you know, initial for getting a job, then they will go to the maybe the army or the, you know, the military sector. And the military sector, actually, they are asking first for the fitness. And one of the fitness elements is the visual acuity. So those people will end up sitting at home without a degree, having no license, depending on the others on their daily life, you know, kind of things. So that will lead to disability. And we don't want actually any disabled one in our community. So that's, we have to take our part and our role to elevate this disability from this segments. So what we have for our keratoconus patient, there is non-surgical procedure, as we know, that spectacle or the contact lenses, and the surgical actually advances in the recent years that start with the innovation of the cross-linking, which actually is very, very, very powerful procedure that can be done for keratoconus to help the progression. ICR, intercorneal rings, it's a surgical option. ICL, the intracontact lenses, or the keratoplasty procedure. So what is available, if you ask yourself now, what's available in your practice, you know, for your patient? Some of us will say only spectacle, and some will say, okay, maybe contact lenses and maybe cross-linking, and we can refer, you know, for the other surgical procedure in other centers. So this is lead to we asking ourselves, what can you offer to your keratoconus patient? If you detect a keratoconus patient, what is your management will be from an optometrist point of view? So most of the time, if you are having difficulty answering this question, the keratoconus patient, definitely they will have a disability, and plus also difficulty to find the optimal management. And I don't call it treatment, and I call it keratoconus management, because there is no such treatment for keratoconus. The surgical procedure which done for keratoconus, either keratoplasty or other things, is not a permanent, you know, treatment. It's actually a management way. When we use the contact lenses also is not like a treatment, okay? It's like a management way. Like when you have a diabetes patient or a hypertension patient, they are taking their pills or their injection, so they control, you know, the condition they are having, but they don't have a surgery like such to relieve them from this long life disease. A keratoconus simply is like this. I want you now to get a screenshot maybe of this paper, because this is one of the very important paper that optometrists, I think, and the ophthalmologists should put in their clinics, especially those who are managing keratoconus. This paper published, I believe, in 2015 in one of the prestigious, as we said, journal. It's the Cornea Journal. And this paper titled as Global Consensus on Keratoconus and Dictated Disease. So if you see these names, all the names here, no one of them an optometrist, by the way. No one of them an optometrist, no one of them a doctor of optometry. And most of them, they are well-known surgeons. They are professors and clinicians, okay? And I believe they gathered, if I recall, the study very well, I believe they are gathered something like 13 specialized keratoconus surgeons. And if you notice the names of like well-known worldwide, professors like Michael Bellin and Nato Ambrosio and Bellin, they are the ones who invented, that the Pentacam diagnosis modality and grading system for the Pentacam. So they are very in the keratoconus management. So what they did with these professors, or the panels, they actually asked them to define from their perspective and clinical experience, they define the keratoconus, they stage the keratoconus, and they set the criteria for the diagnosis, and they set criteria for the management. Okay, so please go back to this paper and read it very well. I will go through it, but I will go through the important point. This is the, the mechanism of their working, how they, the 12 experts, okay, and they divided them like to 3 groups. They send them emails, asking questionnaires about certain things, and they get the replies and then filter it, and they can come up with this, summary graph and the summary chart. Please concentrate with me. If you face a keratoconus patient, according to those expert people, okay, on the field, keratoconus patient, okay, advise them not to rub their eyes. This is the first point. Either they're having allergic or they don't have allergic, okay? So ask them not to rub their eyes. And then what you will do, if they are having allergy, you have to prescribe them medication. If you are an optometrist not allowed to prescribe, a treatment, eye drops to manage, the allergic conjunctivitis which they are having, you can refer them to the ophthalmologist. They can prescribe them that drops. So, and then you consider the cross-linking if they are young. And the definition of young here, they are saying if it's below like 20 years of old. So if they are below the age of 20, you cross-link them straight away. You don't wait for the progression to happen. Again, when you finish, the cross-linking procedure, then you do a refraction for them. And if they are good with the glasses, you just let them, have that glasses and manage that way. If the glasses vision is not satisfactory, you try the contact lenses. And if you notice here, they mention even that scleral contact lenses, because now worldwide, it's gaining a very good reputation in managing even severe stage of keratoconus or even post-surgical procedure with these lenses. So if they are happy with the contact lenses, then it's fine, okay? If they are not happy, so that cross-linking and then glasses or contact lenses. If satisfactory vision, they continue with their glasses or contact lenses. If they don't have a satisfactory vision, then they go and search for another procedure modality like the ICR, the intracorneal rings, or the intracontact lenses, whatever is suitable procedure for them according to their cases and the decision of the surgeon. Or they can go even for the further procedure like the DALK, deep anterior lamellar keratoplasty, a new modality of keratoplasty, or even the old full thickness corneal transplant. But after that, if you notice, okay, let's go back. So I want put this down. So after the procedure, the surgical procedure, again, you refract them. They might need, again, glasses or contact lenses, and they mention especially also that scleral lenses again and again. So if you notice that the first initial detection of the disease is start with the optometrist. Sorry. It starts with the optometrist as the first, gate for those patients to be diagnosed. And then they manage after the cross-linking by the optometrist, either by glasses or contact lenses. And then even after, if they have a further procedure, which is surgical procedure done by the surgeons, then they will come back to you to manage them again in the management way that you are having in your clinic. So what's now the role of optometrist in keratoconus management? Early detection is very important. Early referral now for cross-linking also is very initial. Please, if you don't start until today, your specialty contact lens practice, please start it. Education and the awareness. This is one of the presentations that we are sharing, in our region. So continuous education regarding, the keratoconus and keratoconus management is initial role of the optometrist as well. Update your knowledge about the latest technologies and procedures. So let me go back to the eye surgeons. What they can actually give to their patients from their management point of view. They are very good in keratoplasty. They are very good in intracorneal rings, ICLs, the different surgical procedure to manage their keratoconus patient. And they might answer the usual questions of the patient. The patient, what they ask, the surgeons when they go to them, they ask them, Doctor, كم نسبة نجاح العملية? What's the percentage rate of this surgery which you are going to perform to be successful? Okay. And actually, no one of the patients should ask such question. They should ask instead a question: what is my final visual acuity after your surgical procedure will be? Because that question is very hard to any surgeon actually to answer. But they can answer actually what's the success rate. Some of them they will say 80%. Some of them, according to their experience, the previous experience they having from their previous patient or surgical procedure they have done. But they cannot actually answer what is my final visual acuity after the corneal graft, what is my final visual acuity after the intracorneal rings or whatever procedure they are going to perform. Instead, the optometrists actually, they are very good in retinoscopy and detecting early cases. And we have seen this actually. I have seen myself a referral comes from very early graduate optometry students who just joined, an optical shop, and he started using the retinoscope and picking up a Caesar reflex in somebody who's having actually 6/6 vision. 6/6 vision, and still he pick up a very Caesar reflex, a very faint Caesar reflex. And when we subject, this patient to a corneal topography, a pentacam, it's showing it start to be subclinical keratoconus, which is should be monitored, during, let me say 3 months, very close monitoring, and that show up, there's a progression of keratoconus. So let me say that retinoscope is very easy device to be used. It's very handy to be carried from one clinic to another clinic, let me say, from a remote area where they don't have, that sophisticated machines like the pentacam extra. Very good in refraction, very good in glasses prescription, and they should be also good in contact lenses practice. Very well educated and very knowledgeable about the keratoconus and its management. The optometrists, they should actually be very knowledgeable about the keratoconus management, because it's really one of the core, management for those patient is related to us as optometrists. So can the optometrist show the keratoconus patient the best corrected visual acuity? Definitely. So if any patient comes to you and said, doctor, if they call you doctor, what will be my visual acuity, you can say, you will tell me actually after I'm placing, you know, these contact lenses in your eyes. So the patient definitely will feel. على قولة اخواننا المصريين احنا ما بنبيعش ايه السمك في البحر. يعني احنا بنجرب للمريض بيشوف في النظر، وعلى قولة اخواننا اللبنانيين اذا عم يقشع كويس فاموره معناته انه تمام. So you can show them the result, you know, on the spot, on that time where you do the trial. So keratoconus patient, some of them, they are having a very good visual acuity with the glasses or the contact lenses, but still actually they are looking for surgical option. It's the same like somebody who is wearing glasses for 20 years and then they go and ask for refractive surgery, okay? Maybe they are unhappy cosmetically or whatever, or they are suffering, you know, with their contact lenses. They have to remove it, you know, every night. So there are so many things that actually divert the mind of a happy keratoconus patient visual acuity wise, or the quality of visual acuity wise, actually with the contact lenses or glasses, to divert their mind to go for a surgical procedure, okay? And they are also having, we have also a good visual acuity after surgical procedures that be done for keratoconus patient, but still they are not satisfied actually about the quality of vision. And we are not talking here about the quantity of vision. You might actually test in your clinic a patient who is having like 6/12 vision and you see, this is a very satisfactory visual acuity. Yes, but that is 100% contrast. You are testing a patient on a clinical setup where you have that screen, a black and white, you know, symbols there, you are examining there, but when they go to the real life, where the contrast is different, okay, the environment is different, the lighting is different, their visual acuity might drop very poorly. So we don't say that 6/12 vision for a keratoconus patient should be satisfactory. If we can get them with a better quality of vision, that's actually it's our mission. So they are not happy about surgical procedure. We have met many actually patients, they are not happy after, you know, their surgery because their expectation before the surgery was high. Unfortunately, because maybe the surgeon, they didn't control, you know, the expectation of their patients. And the patient, they think after the keratoplasty, they said, خلاص الدكتور غير لي قرنيتي فمعناته أنا ما عندي قرنية مخروطية فالمفروض إن النظر يكون كويس. صحيح؟ There's no such like things. Okay. So a happy patient with a very good visual acuity, both surgical procedure and contact lenses, also we have come encounter such cases. Please dedicate some more time to a keratoconus patient, talk to them and see what is that, you know, part of their life you can help them with, either with their visual acuity, either referring them to a good, you know, surgeon they want to go to, either to give them some education about what is the possibility, you know, after the surgical procedure, how they care about their contact lenses, whatever. So how can we make keratoconus patients happy? It's very easy. We can give them the best quality visual acuity. If we start our specialty contact lenses, I think this will be one of the good idea. Less invasive and stable, comfortable treatment, and treatment, as we said, better to be called a management. Affordable and less expensive also management way. Listen to their concerns and try to help and support them when needed. We know that contact lenses is being linked to a keratoconus and vision since long time, but unfortunately the first generation of these contact lenses is being developed by people who are not knowing too much about the physiology and the anatomy of the eye and the cornea. So the material being chosen is not suitable, and also the design was not suitable. So that was the first generation of contact lenses with the BMMA material, zero oxygen permeability. It can give a good visual acuity, but unfortunately it doesn't respect, you know, the health of the eye and the oxygenation which needed. But now in the market and in the recent, you know, let me say the recent years now, there's immense, you know, this development of different modality and type of these contact lenses. We have now the RGB lenses. We have the soft specialty contact lenses that designed for a keratoconus patient. We have the hybrid lenses. We have the scleral lenses. And we have the material, which is a very high decay, and we call it now a super decay even materials is there. So it's give us, more privilege to manage our patient with these specialty lenses. I think that Dr. Basim Adlegan will talk about this later on in the next presentation. Challenging cases like before, the first case, the pilisoid marginal degeneration, which you have, this shape, which is like steepening from the periphery, the central flattening is very difficult to be fitted long time with some modality of corneal RGB lenses. We can fit them now, that we say with the scleral lenses, keratoglobus cases as well, or the post-refractive surgery ectasia, when you have, the center of the cornea very ablated by the laser, and then you have this, shape, which is from the center is like having a very flat area. You cannot fit regularly, that soft contact lenses or even the corneal RGB lenses. Corneal graft patients, we don't want to insult any corneal graft. So better to use a modality of lenses that it doesn't touch actually the cornea. There is some doctors and some optometrists, they believe a very severe cases of keratoconus cannot be managed with contact lenses, but in our clinical practice, we found that even a very severe cases nowadays, okay, and very advanced cases can be managed with the specialty lenses. This case, if you see, that anterior corneal OCT, which is showing a corneal thickness below 300 micron, 288 micron, a very thin cornea, and having a scar as well, post eye drops that happened for this keratoconus patient, unfortunately, and having the uncorrected visual acuity counting finger 2 meters, but we managed to fit them with scleral lenses very successfully. And I know this personally, this patient's been now like 5 years in their contact lenses. They are happy. Nothing happened to them, Their cornea is not like bulge or pop out, or what the myth is being told to the patient that your cornea will tear away. Other cases with post-ectasia, I'm not talking about the different cases because this will be maybe my next talk next week. So post-corneal graft as well, post-ICRs. Take-home message, please. Keratoconus is a real existing problem in our society. Keratoconus patients are young and they will need our help, and we are capable actually to help them. Early diagnosis, it does matter in their cases because now we have, as we said, a procedure that can help the progression if it's early diagnosed, which is the cross-linking. If diagnosed early, we will get better prognosis. Please use retinoscope for your screening in your clinic, whatever the setup you are having. And optometrists have really a major role in keratoconus management, and the newly designed specialty contact lenses can rehabilitate the visual acuity of keratoconus patient in any stage. And when we said any stage, it's any stage, and even post-surgical cases. Please start your specialty contact lenses if you didn't start yet. Thank you so much. If there's any question, I'm sorry if I go very fast, with the presentation.
Thank you so much, Mr. Shamli, for this informative and nice lecture. We will start now with the questions. Okay, so we have one question. Doing cross-linking at young age will help a lot, as you said, but can it in some cases not work? What should be done then?
If I understand, the question, it's saying that if you have an early keratoconus diagnosed patient below the, let me say, the age of 20, or what's the age?
Yes, she means below 20 years.
Okay.
And you said that cross-linking will help a lot in this kind of patient.
Yes,
She's
definitely.
asking, it might not work sometimes, right?
As far as I have seen cases, you know, because when you do the cross-linking is now is very initial, you know, procedure actually to be done for any keratoconus patient who been diagnosed under the age of 20. This should be clear, you know, for everyone, for the surgeons, for us. So what will be the other choice if we don't cross them? If you cross-link them once and you keep monitoring them, definitely after the cross-linking, you will not leave the patient and tell them, okay, you are now, your cornea is not progressing anymore. So we don't want to see you in the clinic forever. Just use your glasses, maybe you change it, you know, frequently or whatever, okay? We are not saying this, you know, for the patient. We are telling the patient, actually, you have now, okay, done a surgery, which might help the progression, but still you need to come back for a review and for monitoring, you know, the cornea. So we give them like periodically, you know, visit, like let me say every 6 months or even every 1 year to repeat the corneal topography, the pentacam, to rule out, you know, any progression happened. And is there some cases, you know, will need, you know, a cross-linking procedure? Yes, I think literature is saying some, but not that, you know, amount of patients, which we consider, you know, that a huge to say this procedure is not working in young, you know, keratoconus patients.
Okay, Mr. Shan. Another question. You said also that rubbing is a factor for keratoconus.
What is it?
So,
rubbing? Yes, eye rubbing, yeah.
Yes. Is the rubbing alone a factor, or it should be associated with other factors also? And if someone doesn't have like a hereditary issue or doesn't have any other factor related to keratoconus, does rubbing alone cause keratoconus?
Predisposing factors of keratoconus, actually, which is recorded very clearly in the literature, they're saying there is some, you know, multifactorial kind of things associated with keratoconus. Is not only the eye rubbing itself, you know, but maybe the eye rubbing will be like the trigger, which is, you know, actually start the disease. So maybe you have the genetic ability, you know, to have a keratoconus, but you don't rub your eyes, so will not progress, you know, to a keratoconus, or it will start and then it will stop. But if you have that genetic factors and then you rub your eyes harshly because you are having, you know, allergic, which is not treated, maybe these two combination will reflect very badly in the stage of your progression. So let me say, is eye rubbing alone is not only the factor, but we should tell any child who's rubbing, you know, their eyes, either they have a family history of keratoconus or not to rub their eyes. And why actually they are rubbing? Because they need a treatment, you know, for their condition, or at least, you know, a managing, you know, therapy and a very close review. So the answer, eye rubbing alone might not be not only the السبب الرئيسي يعني للكيراتوكونس.
Okay, another question. Why we put surgical options as a treatment of keratoconus, and we know it doesn't affect well. I don't mean cross-linking, but other surgeries.
Okay. We as optometrists, we are not surgeons, okay? So we know something about the keratoconus patient. Keratoconus, they need a good visual acuity. Actually, their main problem is not how their cornea it looks like, okay? It's not, you know, what will happen, you know, to them like after, let me say, 10 years or whatever. Their main concern, actually, the visual acuity that they are having. So if we can help them with their visual acuity, this is as part of non-surgical management, as we said, from our side as optometrists, okay? But the surgeons, they are seeing the shape of the cornea, which is very steep and is causing, that visual acuity to be not sufficient for the patient. So they try with their expertise, as in corneal graft or the ICR or whatever modality they want to use on this patient according to, the stage and the case, okay, and then decide to do that surgical procedure. There's nothing wrong, to do the surgery, but the things you have to be clear, with the patients. And you say that I'm not performing the surgery to get you rid of your keratoconus, disease, okay? I'm going to try to flattening that, cornea by the surgery that I'm performing, but unfortunately, I cannot predict what will be your visual acuity. But also, unfortunately, we have a patients or the patient's family who are insisting in the surgical procedure, even if they are knowing, there is a possibility of visual acuity not going to improve, and maybe there will be a consequences of rejection, consequences of inflammation, consequences of a steroid, prolonged steroid, effect. So there are so many things, related to the choice of surgical procedure. Either it's from a pressure from the patient themselves because they are not convinced about only having, like contact lenses for their visual acuity for the rest of their life, and they want something to, لأنه إحنا طبعنا إن نحب نتخلص من الشغلة نهائي. فاللي بيلبس نظارة ما عم بيرتاح مع النظارة وبده يروح يعمل عملية اللي هو refractive surgery، بده يعمل ليزك بروسيجر مثلا، صح؟ مع إنه هو نظره ممتاز بالنظارة، okay? So he's going to take the risk of the refractive surgery as well. So it's the same for keratoconus patient, and the difference is that keratoconus patient, unfortunately, and there is a fault from our side as optometrists also, we don't show them the very good quality visual acuity. So if they don't see a visual acuity, which is a sharp 6.6 like, okay, without any surgery, they are going to look for a surgical procedure because they said in their mind, or they put their mind, okay, after the surgery, my visual acuity maybe is going to be improved. So please, as an optometrist, you have to show them what is the best visual acuity that you can reach with a small, device and very uninvasive, type of management.
Okay. Another question. So you talked a lot about the importance of using a retinoscope to detect the keratoconus at very early stages. There is a question here. If they don't have a retinoscope at the clinic, is there any other way that they can benefit from?
Yes, but unfortunately, it's not like an early stage, okay? Let me see that we use the autorefractor most of the time, okay? And autorefractor, we have that screen, and we have, the Myers. If we see that Myers irregular, okay, or the reading keep fluctuating, or the K reading, let me say, is below the 7 mm, or very steeper than, let me say, 46 diopter, then we consider there's something wrong, with this with this refraction or with this patient. So then we doubt, especially in the patients or the subjects which are actually very, very young, let me say in the age of 15 up to 20 years of old. In that stage, that will come in your mind, there is something wrong. But what is the power of the retinoscope? The power of the retinoscope, it detects even before this stage, which is not showing, even on the slit lamp. So most of the time when we detected these cases, we confirm it, okay, by using the pentacam. And when we do the pentacam, and we see there is a keratoconus, but most of the time will be like off center, as we said, is not on the center where the Myers of that autorefractor, illustrating on your examination.
Okay. So
A retinoscope, by the way, sorry, Rana. A retinoscope, by the way, is very cheap, and very handy to be used. And I don't see any harm of using the retinoscope for the patient. I'm not saying do the refraction for your patient, by the retinoscope. You have a very good machines now in the market, very good autorefractor, which gives you a very details, you know, about the refractive status of the eye. But I'm saying, please use the retinoscope to screen the media. يعني احنا مثل ما بنسلم على الشخص بناخذ اخباره، شو اخبارك، شو عامل، شو صار عندك، نفس الشيء. انا بشوف انه الاوبتومترست حقيقه الريتنوسكوب بيعمل له نفس الشغله، بيسلم على العين. يعني انت بتسلم على القرنيه وبتسلم على الفيترياس وبتسلم حتى على الرفلكس اللي جاي من الشبكيه، فيعطيك مور ديتيلز. يعني you can pick up early cataracts patient, you can pick up يعني early cases of keratoconus, you can pick up a hemorrhage, you know, from the vitreous. Whatever in the media, it will be reflected on your, you know, that the image or the reflex is coming from the retinoscope. So I'm not saying do please the refraction by doing, you know, the retinoscope. I say do the screening by using the retinoscope.
It's a very nice description. Another question, if I prescribe contact lenses for keratoconic patient today, are the curvature measurements will be stable, or we have to change the contact lenses after 6 months?
Sorry, if you can just repeat, you know, the question, if I understand it. It's when you prescribe, you know, the contact lenses, what will happen?
If you prescribe contact lenses for a keratoconic patient with specific curvature measurements.
What is it?
If you prescribe contact lenses for a keratoconic patient with a specific curvature measurement.
Okay.
Are these measurements stable, or we have to change the contact lenses after 6 months?
Okay. Although this question is beyond the scope of this lecture today, but I'm going to answer it. Now in our hands, you know, there is so many entity comes under this question. First of all, what is the age of this patient? What is the stage of keratoconus? Is the cross-linking has been done or not? Okay, still this cornea is progressing or not? What is the modality of contact lenses you are using? I think the one who's asking this question, he is referring to a corneal RGB lenses where we depend on the curvature of the cornea, okay? When we generally, when we prescribe a contact lenses, we don't tell the patients go for 6 months or go for 1 year or go for 2 years without a revision, you know, without reviewing those patients. So definitely we'll keep reviewing them. Let we say periodically, let we say after 3 months, after 6 months, maybe then later on, and maybe after 1 year. If we notice there is a change, okay, we should advise accordingly. But we cannot answer like generally there will be a change for all the patients. No, usually when we prescribe, you know, the RGB lenses, still it will run with the patient like for 2 years, sometimes even more, you know, without changing them, even if there is a minute change on the curvature of that cornea. And with the new modality, by the way, of scleral lenses now, the specialty lenses, we are not working actually on the surface of the cornea. We are working beyond that. So we are not caring about if there is a change or not. But I will tell you something which is very important. If somebody who is below the age of 20 comes to my clinic and I diagnose that case as a keratoconus, whatever is the stage, and I try the contact lenses, let me say the scleral lenses, and I show them the best corrected visual acuity, which is 6.6, I will not prescribe the contact lenses even if they want it. But instead, I will refer them to do the cross-linking first. So I will refer to the surgeon ophthalmologist to do their part, do the cross-linking, because their age is below 20. So they do the cross-linking, and after like a month and a half, or let me say 2 months, they can come back to me and I again refit, you know, the contact lenses and do the trial and then prescribe. Why? Just to guarantee there won't be a change. And by the way, if there is a change going to happen beneath the scleral lenses with an uncrossed, you know, cornea, the patient won't feel it, because these lenses is masking any irregularity comes beneath, because we are using a fluid. When it comes, you know, to the scleral lenses presentation, maybe we can talk more about this. But I hope I answered, you know, the question that's been addressed.
Yes. Okay, there's a question about corneal transplantation.
Your voice, Rana, I think it's like very, I cannot hear it, you know.
Okay. So
Sorry?
now you can hear it?
Yes, yes.
Okay. So if a patient has keratoconus and he underwent corneal transplantation,
Okay.
does keratoconus might occur also after the corneal transplantation?
Okay. We should know the anatomy, okay, of the cornea and of the procedure also of the transplant. Okay. There's different modality of transplant now. And in all modality, they are not going to change the whole cornea from, let me say, the limbus to the limbus. There's no procedure such like that one, okay? So there is still will be a part of a cornea of the original patients, which is having a keratoconus disease, and then the other cornea will be fixed, okay, on this part and stitch. And after that, let me say after 6 months or 1 year, that stitch is going to be removed. And when you remove the sutures, okay, when you remove these sutures, definitely there will be again a change in this corneal curvature, because that part of the original cornea definitely will be pulling, and the stitches, you know, that scars which happen there will be pulling from one side or the other side. That's why after the procedure, the surgeons will do something called planned suture removal. Whenever they want to remove a sutures or they do something for the patient, they should do corneal topography to see what is the status of the cornea. It's deep from where, so I can relieve this. And sometimes even they do additional, you know, stitching. And all this, you know, information that actually giving us a hint that the cornea after the transplant is not stable. So it might getting more flattening, it might getting more steepening, the visual acuity might improve, the visual acuity might remain the same, or even getting worse. So if somebody is saying that keratoplasty is going to get rid of the disease, is not going to get rid of the disease. That is my answer.
Okay. So there's another question. When can a patient be fitted with contact lenses before undergoing cross-linking?
Can the patient fitted with contact lenses before
with contact lenses
before the cross-linking?
Before undergoing cross-linking?
Yes. I'll tell you what is the scenario now is happening, you know. The scenario what is happening that we will meet patients who is diagnosed as keratoconus below the age of 20. Those cases, definitely, we will do the trial of contact lenses on them, but we'll show them, you know, and we show their relative, because most of those patients, they are very young. They cannot decide in our, you know, part of the board, you know, and unfortunately, we don't decide for ourselves. The family, they are deciding for us, you know, what is the right things to do. So please, when you have a keratoconus patient below the age of 20, ask the family member to be around, you know, during your test. So show the patient and show the relative what is the visual acuity before the contact lenses, what is the contact lenses on the fitting, okay? And explain to them that this is the visual acuity without a surgery, okay? Without a transplant, without ICR, without rings, okay? Very good vision, very good quality of vision. But I'm not going to prescribe, because there's a very important surgical procedure has to be done to halt the progression, because the scleral lenses or the RGB lenses is not going to halt the progression of the keratoconus. What is that procedure? I advise them to go and do the cross-linking. When they do the cross-linking, they can come back for the fitting. This is if their age below the age of 20. Okay, done. If they are saying, okay, but now they have like a secondary school, they have to sit for the exams, we want something to help them with their visual acuity, I'll say no problem, I'm going to order the lenses, but please, as soon as possible, you go and do the cross-linking. And please, you take this responsibility, because if your cornea is progressed and you come for a review and we found that the cornea is progressed, we are not taking this responsibility. And the other segment of patients that come to your clinic, they will be more than the age of 20, and say more even than the age of 25, or the 30. Those patients that you can fit them straight away with the contact lenses, but you have to tell them to come for a review, like every 4 or 6 months to monitor the status of the cornea. If you notice a progression after the age of 20 or the age of 25, please refer them again for the cross-linking. And if somebody is asking me, you know, after the cross-linking, are you going to change, you know, the parameter, let me say, of the scleral lenses? Most of the time, no. Most of the time, no. And maybe if there is change, there will be a new change, not necessarily to change the lenses, because the lenses is very expensive and it will run with them like for 2 or 3 years more. Okay, so there is no harm. But if they want to change it, why not?
Okay, Mr. Shami, the last question for today's lecture. Can cross-linking be repeated in case it doesn't work in the first time?
Okay, cross-linking can be repeated, yes. Cross-linking simply can be repeated, but please see, I have come across some patients when they come to me, okay, and they have done the cross-linking, and they will come for me for a second opinion and saying, we have been to an, let we say, optical shop, or we've been to a hospital and we've been examined, and the people there, I don't know, the ophthalmologist or the optometrist, told them there is a progression. How they would know the progression? They said because they came like 2 years back and their refraction, let we say, around like 3 cylinder on their glasses. And now they are having a refraction like 4.5 or 5 cylinder, okay? By only the refraction, you cannot tell a cross-linked patient there is a progression. You have to have a baseline corneal topography, and you have to study very well that corneal topography and compare it with another corneal topography, and probably is taken by the same, you know, machine. Like if we do pentacam with pentacam, with Placido disc technique with Placido disc technique, just to compare, you know, if there is a progression and change, and then you can tell that patient you have a progression. But based on the refraction, you cannot tell the patient. Based on the keratometry reading, you cannot tell the patient there is a progression, okay? Why? Because it is different from one-to-one in prescribing, a different one-to-one to record, you know, this data. So only the cutting edge is the corneal topography. If there is a difference in the corneal topography, and let's say that difference should be, you know, addressed very well. Let we say that the corneal thickness before the surgery was, let me say, 450. After the surgery, after 3 months, it was like 420. Is that a change? Is not a change, because the procedure itself, you know, it might cause a little bit in reduction on the thickness of the cornea itself. But 450 initial reading of the thickness, and then you get like 350. No, there is a change on this case. So please be careful when we say to the patient, there is a change in your cornea after cross-linking and you need to be re-cross-linked again. I hope that is clear.
Thank you so much, Mr. Shamli.
If there is more question, I'm sitting, and it's fine. It's my, you know, pleasure actually to answer any question.
Information عن جد. رح نكتفي نحن بهدول الأسئلة هلا لأنه قطعنا الوقت كثير هلا. Thank you so much, Mr. Shamli. Thank you all for attending this lecture. Please بدي منكم بس please في عنا survey بتاخذ من وقتنا like 2 minutes بس. Please fill it up بس تخلصوا من lecture. I will leave it now to Amir.
يعطيكم العافية. ثانك يو لكل عفوا ثانك يو لكل اللي حضروا معنا اليوم، وبتمنى من بكره رح تنزل المحاضرة للتسجيل تبع دكتور باسم الليجان. بتمنى من الكل يبلش تسجيل من بكره، وان شاء الله يعني بهيدي الفيدباك اللي رح تعطوها بالسيرفي نحن بنعرف انه بكل لكتشر ممكن يصير اي ميستيك اي شيء، بس لكن انتم اذا ساعدتونا بهيدي السيرفي انا باكد لكم انه كل مره على مره رح نكون افضل ورح نكون مور بروفيشنال، وان شاء الله بنكون عند حسن ظنكم بالمره القادمه كمان. انا بدي اشكر كثير استاذ ناصر على هيدي المحاضره القيمه، وان شاء الله نحن وياك مش بس بهيدي المحاضره، بسلسله محاضرات. وانا بدي اقول لك انه اجاني اكثر من تعليق عليك انه شخص حبوب ومحبوب جدا من الاشخاص اللي هلا عم يحضروا، يعني بعثوا لي على البرايفت. استاذ ناصر انا بدي اشكرك مره ثانيه، بدي اشكر كل الاشخاص اللي كانوا موجودين، وبتمنى انكم تتابعوا معنا كل محاضراتنا. محاضراتنا كل نهار جمعه رح تكون من هلا ل 1 ابريل، قبل ما يبلش رمضان بنكون ان شاء الله خلصين كل المحاضرات. رح نوقف خلال شهر رمضان لمده شهر، ومن بعدها رح نرجع نبلش محاضرات ثانيه. المحاضرات الثانيه رح تكون بعناوين جديده وعناوين اقوى ان شاء الله. يعطيكم الف عافيه.
أنا سعيد أخوي أمير بتواجدي طبعا بينكم، شكرا جزيلا لكل اللي حضروا، طبعا أعطونا وقتهم، هم اللي إحنا ممنونين لهم طبعا. وبوعدكم المحاضرة القادمة تكون يعني أيضا انترستنج نفس المحاضرة هذه إن شاء الله. تحياتنا لكم.